Welcome back to season 2 of Reboot with Dr. Arasi Maran. I'm your host, Dr. Arasi Maran. I'm a board certified interventional cardiologist who's been in practice for more than 10 years. And I started doing this podcast as a way to share evidence based information to anyone who is interested in their health. And everyone should be interested in their health. And also to try to send the message that it is never too late to reboot and reclaim your health. And I hope this serves as a platform for you to, as a source of information. So today I have a very special episode planned for us. I'm thrilled to introduce my brother-in-law, Dr. Raja Pullatt, who is a board-certified cardiologist whose expertise spans multiple dimensions within the heart health. He currently serves as a program director of internal medicine residency at Rutgers Health at Trinidad's Regional Medical Center, where he also holds the title of clinical assistant professor at the Rutgers New Jersey Medical School. As a graduate of JJ Medical College in India, Dr. Pullatt completed his internal medicine residency and cardiology fellowship at University of Connecticut. And then he also served as a chief medical resident there. He was also the chief cardiovascular fellow, and along with the prestigious R.F. Rainfrank Award for Excellence in Teaching. He loves to teach for sure. Dr. Pullatt's impressive credentials include a fellow of both American College of Cardiology, American Society of Nuclear Cardiology with board certifications in internal medicine, cardiology, echocardiography, cardiovascular CT, and vascular ultrasound. Beyond his academic accomplishments, Dr. Pullatt maintains a private practice at Union, New Jersey, Union County Cardiology Associates in New Jersey, where he provides comprehensive cardiovascular care. Today, with Dr. Pullatt, I would like to explore multiple different things, but focus mainly on lipid panel, which is a very common blood test, which we do for patients who are at high risk for heart disease. I want to deep dive into the different components of lipid panel and what interventions we can do when your lipid panel is abnormal. So let's go to the show. I hope you enjoyed today's episode. First of all, Raj, thank you so much. You are the first episode in the second season, so I really appreciate you taking time to doing this. Why don't we start off with you introducing yourself a little bit more and tell us your path and journey to where you are right now?
Okay, so Arasi, first thing, thanks for having me here. It's a privilege to be on your podcast. I've been following your podcast journey for the last year or so, and it's amazing the growth you've shown so far. And I
Thank
think
you.
disseminating cardiovascular health and overall health knowledge to the public is extremely important. So, in terms of me, I studied in India. I did my medical school in India. I moved here to the US for my residency. I did my internal medicine and cardiology fellowship at University of Connecticut. And then I moved on to New Jersey. I took up two positions. One, I joined a private group practice. And then the other position of mine was involved in teaching. So I was involved in teaching the cardiovascular fellows, rotating at a community hospital. And as the years went by, I embedded myself more into teaching. So I'm currently the program director of internal medicine residency program at New Jersey.
I think it'll be a miss to not to talk about all the different board certifications you have. I mean, somehow you Pullatt brothers have this gene to excel in whichever exams you take, whether it's step 1 or step 2. I remember you getting an almost perfect score of 99 in both the steps. And then you are echo board certified, nuclear board certified, apart from internal medicine and general cardiology. Am I correct?
Yes, and vascular ultrasound and cardiac CT. But yes, that said, maybe it's something in our educational system we had back in India, which helped us.
So, Raj, so let's, I want to talk about something which is done very commonly, a blood test, which is the lipid panel. It has all these components, and I thought we could deep dive into the different components of the lipid panel and go beyond, just the levels, etc. So, do you want to just start with, what is the so-called good cholesterol, bad cholesterol paradigm, and what is the value in it? In today's sense?
So when patients are told to go and get a lipid panel by their doctors, what you end up seeing when you see a report is few components. You see a number reported as total cholesterol, and then the breakdown of the cholesterol patterns, right? So you have low density lipoprotein levels or LDL levels. You'll see that. You will see HDL levels, high density lipoproteins. Then you'll see triglyceride levels. So these would be the big parameters you're going to be looking at. And then you may also see something called VLDL levels. Out of this, what I want our listeners to pay attention to is the LDL levels and the triglyceride levels, and also some amount of attention to the HDL levels. So when you think about it, in our body, we make some proteins called apolipoprotein B, which is the protein which carries certain types of cholesterol. Okay, it carries both triglycerides, which are fat-rich cholesterol, and carries low-density lipoprotein cholesterol. So this protein is what is also implicated in the pathway to atherosclerosis or hardening of the arteries and plaque formation. And that's a concern. So cholesterol, which is carried by this protein, can be dangerous. So if your levels are higher with these ApoB carrying proteins, that can be dangerous. It can herald future heart attacks and strokes. So we want to keep that LDL level low. Traditionally, that's all we've thought about, but now we are learning to understand that it's not just as simple as keeping a level low. You could still have a lot of residual risk, even if you treated the LDL to low levels.
Because a lot of patients, will come back and say, I've been following my cholesterol and it's always been under fantastic control, but why do I have a heart attack? Can you explain that mismatch between low LDL levels and still having a heart attack?
So I face this every day in my practice, and unfortunately, even the labs do a disservice to us, right? So when lab parameters are reported, LDL level, normal level is between 0 to 99. And then I'm telling, my patient in front of me, maybe a middle-aged male who's had a heart attack a few years ago and is coming to see me in follow-up, and he's already on 2 medications, and now his LDL is, say, 80 milligrams per deciliter. So it's not even showing up in the red, it's showing up as a normal level for him. And I'm telling him here, look, sir, I think we need to add something more to get your LDL to even lower level, and they just don't understand why we're doing this. And there's clearly medical sense in doing this, and what I can tell you is that levels are not the same for everybody. We need to individualize it to patients. So if you're dealing with what we would call a secondary prevention population, that is people who already had a cardiovascular event, right? So if you've had a heart attack or a stroke, or if you're diabetic, if you're diabetic, that itself is an equivalent to having heart disease, because having diabetes puts you at very high risk for these events. So when you have these conditions, those normal levels of LDL may not be sufficiently normal. That is abnormal for you because your arteries are starting to have plaque deposition even at those levels. So you need to get it lower and lower. And that target number has changed over the years, as you know. Probably when we were in medical school, that target was like around 130. And then now we've come down to less than 55. Right?
Yeah, it went between 100 and 110, and then less than 100, and now it's like less than 70, and now 55. Yes.
So this target is a moving target, and what we are understanding more and more is that we need to individualize this target. So there could be people who say, I have an 85-year-old or a 90-year-old patient who may have had LDLs in their hundreds and they've never had a cardiovascular event. I'm not going to be aggressive in changing targets, but a younger patient who's having or who's at risk of cardiovascular events, you need to lower their target.
And you see so many patients, just keep dumping medications to decrease their triglycerides, but don't understand the direct correlation between blood sugar and triglyceride levels. Do you want to talk briefly about that?
Exactly. So, when we see patients and you see that lipid panel and you see that number, one of the numbers in the lipid panel is the triglyceride level. And when you see a high triglyceride level, alarm bells should ring, right?
Mhm.
Because you have a certain type of patient you're concerned about when you're high triglycerides. It's really what we call the metabolic syndrome patient. These patients have impaired glucose control. So either they're overtly diabetic or they're going in the direction of becoming diabetic in the next few years. Uh, and triglycerides are what I call, the fat carrying uh, cholesterol protein, right? So you have all the fat absorbed, but it's not really the fat which is the problem, right? It's not the fat. It's basically the carbohydrates we eat, which is converted to fat by the liver. So really, to lower triglycerides, what we need to do is lower carbohydrate consumption. And
Mhm.
unfortunately, in the last half a century, dietary patterns have changed. More refined sugars are being used. Overall, uh, that has led to this development, and I guess I would say a pandemic of metabolic syndrome. I would say probably, depending on the population you're studying, anywhere between a quarter to half the population might be having metabolic syndrome.
Yeah, I mean, the metabolic syndrome is just increasing so rampantly, and we are seeing children with metabolic syndrome and impaired glucose tolerance, and just and everyone seems to be focusing on different things based on their own interest levels. One person will be focusing on blood sugar levels, and one person focuses on aggressively on cholesterol levels, and I think not looking the whole picture. And I wonder sometimes we are so close to the tree that we are missing the forest and the overall health paradigm, that it's just not what you eat, it's what you do in between your meals, it's what you do before you go to sleep, it's the amount of stress you carry, it's everything, it's day-to-day life. And we have to prioritize and pick and choose, like, just not one thing, but focus on everything overall. Another big discussion which goes back and forth right now is lipoprotein little a. I feel like people are just overtly focusing on lipoprotein little a. Can talk about that, Raj? Like, why is it important, and what does it do?
So lipoprotein little a, I mean, it's the new kid on the block, at least. I mean, it's not new in terms of knowing about it. It's been discovered half a century ago, but at least based on probably around 15 years ago, we had some seminal articles showing that lipoprotein little a has an independent risk factor for cardiovascular disease that is on top of LDL cholesterol. So you could have a patient who's had a heart attack or who has a family history of having premature heart attacks, who comes to you and you look at their lipid profile, their LDL cholesterol is under control, or at least you got it under control with medications, and they're still having, say, they come back now with another cardiovascular event, like another heart attack. And that raises red flags for all of us. And what we've seen is that it's not just the LDL. Remember, I told you ApoB, which is the atherogenic lipoprotein, is LDL is one of the cholesterols which it carries, but there is triglycerides which it carries, but it also carries this other uh, subparticle of LDL called lipoprotein little a. What the difference of lipoprotein little a is that it has ApoB, LDL
Mm-hmm.
cholesterol. Along with ApoB, it's cleaved to ApoA1. And ApoA1 is the other lipoprotein involved in LP little a. And what we know about ApoA1 is that it has a close resemblance to plasminogen. And plasminogen, as you know, is a prothrombotic.
Or it just increases the tendency to form blood clots.
Exactly, and it's more atherogenic. And what we've understood is that LP little a has significantly higher molecule to molecule. So if you take ApoB containing LP little a versus ApoB containing LDL, ApoB containing LP little a is much more atherogenic.
Mm-hmm.
And so there is like 1/5 of the population who have elevated LP little a levels.
Yeah.
And so now we have this large population which have elevated LP little a. And so far, we've not had any medications which specifically target LP little a.
That was my question. Like, what do you do if you have an elevated LP little a?
So, in the past, what we would do, or right now, what we do currently is uh, keep their LDLs even lower than the targets we conventionally look at, right? So, we try to get them down really low. Uh, there are certain medications currently available which can lower LP
Mm-hmm.
little a. So, unfortunately, the cornerstone medication we use, statins, can actually increase LP little a little bit, but still it's great with LDL lowering. It lowers your LDL by more than 50%. The other medication which really comes to mind is PCSK9 inhibitors, right? So this has been there
Yes.
for close to 10 years now in the market, and we're using this as statin substitute in patients who cannot tolerate statins, or in addition to statins who need lower LDL levels. There has been a 20 to 25% reduction in LP little a.
Even though it decreases the LP little a to 25% or so, but it does not normalize. You'll never see, that's what, like, people always try to think of, oh, I should normalize. And if you have elevated LP little a, it tells you you're at high risk. But even with therapies, you may not be able to normalize the LP little a levels. And I think that's something everyone should keep that in mind. It's a marker, it's a risk factor. It tells you need to overall take care of your health and be very careful about your symptoms, etc. But we are not there as yet. Am I correct?
Yes, so I agree. I mean, LP little a is genetically determined, right? So
Mm-hmm.
unfortunately, the genes you come in with. So if you have elevated LP little a, in the past it was like we used it as a marker. We knew that you have elevated LP little a. That means we need to be more aggressive at reducing all the other risk factors for cardiovascular health to prevent events.
So, so let's just briefly, talk. I mean, when we talk about other risk factors, as you said, reduce your LDLs as low as you can tolerate. We are talking about keeping your blood sugars under even keel, hemoglobin A1C in the early 5.4, less than 5.5 regions. We're talking about blood pressure control. We're talking about aerobic activity. We're talking about reducing your stress levels, etc. So it all comes as a package. And just not this focusing on this one number of LP little a.
Exactly. Two
And
more things I need to say: reduce smoking, right? Stop smoking.
yes, yes,
Smoking
stop or
cessation.
reduce
I
smoking.
know it's not been a big issue the last 10 years or so, but still we see a residual population of smokers. So definitely smoking cessation is extremely important. And in terms of people underestimate the benefit of exercise. Really,
Yes.
aerobic exercise is extremely important to improve cardiovascular health.
I mean, I think, I feel like sometimes aerobic and anaerobic or strength training kind of gets into a battle between each other. It is ridiculous because both are beneficial to the patient and both are equally needed, and you don't want to be overdoing one thing and ignoring the other, and you have 7 days and you want to take one rest day, and you still have 6 days, and you could still do cardio for 3 days and strength train for 3 days and not actually have a fight between the two. So, but unfortunately, it's still, there are cardio lovers and there are strength weightlifting lovers, and they don't seem to find a middle ground. So let's talk about, there are some new drugs coming up in the pipeline, right? The palacarsen and olpasiran, etc. How do these drugs work in modifying the risk profile? And what do you think of them in the pipeline?
Yeah, so I mean, these are new drugs with a mouthful to say, right? The
Yes,
names itself
exactly.
gets you to be in dizzying levels. But one of the big things which have happened in therapeutics is that I think the first therapeutic we had using these mechanisms of using RNA mechanisms came out in 2018 for another cardiovascular disease we treat, right? For amyloidosis, transthyretin
Mm-hmm.
amyloidosis. But again, just to give an overview to your viewers, these molecules we are using to lower LP little a act in a couple of mechanisms. You will hear ASO, which is antisense oligonucleotide mechanism, or siRNA, small interfering RNA molecules. Basically, the long story short, what they do is they prevent your liver from producing this protein ApoA. Remember, I told you
Mm-hmm.
ApoA is one of the proteins required for the LP little a molecule. So, liver produces this protein using RNA, right? So, RNA is your genetic code, which is going to be translated by ribosomes to make proteins. So, now these molecules can go and interfere in this RNA production in different mechanisms, either with an ASO mechanism or small interfering RNA mechanism. At the end of the day, you decrease ApoA production, and that will lead to decreased LP little levels. The interesting thing about this is that you can get 80 to 90% reduction in LP little a levels. So this is uh, groundbreaking because it can really change somebody who was at elevated risk. Remember, when you think about LP little a confers a 4 times higher atherogenic risk compared to LDL cholesterol.
Mm-hmm.
LDL cholesterol itself is atherogenic, but LP little a is 4 times higher in atherogenicity. So if you can actually bring it down to normal levels, like people with very high levels are brought down to normal levels, this can decrease their future risk of cardiovascular health. Again, but we don't have outcome data yet. We
Yes.
have hypotheses. Remember, many hypotheses in the past have failed, right? We tried
Yes.
to raise HDL using
Yes.
drugs, and that never worked out for us.
Yes. Yes.
So
Yes.
these studies are right now in phase 3. In the next 1 to 2 years, probably there may be FDA approvals, and then we'll need to look at like outcome studies to really see that at, at the end of the day, it decreases cardiovascular events.
So, Raj, I kind of want to summarize what you have said so that everyone understands. So let's go back with we are all genetically gifted with whatever DNAs and RNAs we have, and we have, and then some of us, as you said, 20 to 40% of the population have a increased produce increased apolipoprotein little a. And this apoprotein is basically a messenger or a carrier protein, and it can carry the lipoprotein little a, which increases the risk of heart disease by at least 4 times. While there are no direct mechanisms right now, there are some working, which is the pilocarcin or olpasiran, which is going to basically kind of work at the RNA level to reduce the amount of protein which is being made. So since the carrier protein is not going to be there, the cholesterol, the lipoprotein little a does not move around, and that reduces the risk of heart disease. But as you said, it's in phase 3 and we're not there as yet. Maybe in another few more years we will know, and then the studies have to come out to see, even though they work in the lab, is this going to work in a human patient? We are yet to see. Is this a reasonable summary of what you just said?
Yes, it's a good overview of what I just said.
Because it's quite confusing, right? Even for us, they keep increasing and adding and going into such intricate levels of how these proteins are made and transported and come up with little thing. While saying this, you kind of talked very briefly on HDL, which is always historically labeled as the good cholesterol. So let's discuss about that. What do you want? I mean, and especially in South Asian population, the HDL levels are always been tricky, and that is if you have low HDL levels, you are at a higher risk for heart disease. Let's why don't we deep dive into that?
Sure. So, I mean, when you think about HDL, think about it as a carrier vehicle which removes cholesterol from your blood vessels, brings it back to the liver, right? So,
Mm-hmm.
it's considered like anti-atherogenic. It's removing cholesterol from the vasculature, bringing it back to the liver. So naturally, the thought process was that if you have high HDL levels, you're protected, and low HDL levels can be that it's an additional risk factor. And we do consider certain numbers, right? If your HDL level is less than 40, then that is considered a risk factor for cardiovascular events. The problem is it's not as simple, right? Not all.
Yes.
So there is a large population. There is a population of people who have high HDL levels, but we still see heart attacks in some people with high HDL levels. So I tell them don't just go by the number. We have to look at everything else in addition.
Mm-hmm.
And we've also had therapeutics in the past which have looked at increasing HDL and they've not panned out.
Yes.
Unfortunately, so what we tell our patients, if you have low HDL, is the only things which you could do is target all the other risk factors, right? So increase your physical activity, better glycemic control, lower the LDL
Yes.
to even lower levels. So those are the things you could do, and stop smoking.
Yeah. Yeah. I mean, like some of the things which we have tried in the past to raise the HDL number itself, which has not worked, has been niacin, which is very popular still. Like people still take niacin and end up with facial flushing, etc. And the other thing which was touted but did not pan was moderate alcohol consumption, wasn't it? The resveratrol in wine, red wine is supposed to increase your HDL levels, and the French paradox, all that was touted as potentially beneficial and it can raise your HDL levels, but none of that panned out, right? It was basically, yes, it's again like the lipoprotein little a. If you have low HDL, it puts you at a higher risk, but again, we can't focus on the number. Instead, let's focus on things which we know will work, which is reducing your LDL levels and maintaining your blood pressure, things like that.
Agree. I think HDL unfortunately has not been as simple. And the good thing you brought about niacin, right? Niacin can also lower LP little a levels.
Mm-hmm.
But again, in randomized controlled trials, we've not seen a
It did
benefit
not
of
pan.
using
Yes.
niacin. And actually, its tolerability is low. So
Yes.
that's why I'm really excited about looking forward to what happens with these drugs for LP little a. If it'll actually decrease your cardiovascular outcomes, then we've really changed the preventive cardiology paradigm. We have a bigger arsenal to offer our patients to
Yes.
prevent future
Yes.
cardiovascular events.
Well, we will know. People are working very hard on that. So now let's go back to our older medication. And I mean, this has been aspirin. I'm talking about aspirin. It's been there for several decades right now. And I feel like we've gone full circle with aspirin and heart disease. Let's throw aspirin for everyone. Then we move to aspirin to high risk patients. And, we've just changed our minds about aspirin a lot. Can you tell us, can you summarize where we are with the aspirin
Yeah,
today?
I agree. I mean, from offering everybody who's older than 50 years of age to take an aspirin a day, we've gone, uh, don't take aspirin. And then at this point, with all the data we had some good trials which came out 4 to 5 years ago looking at different
Mm-hmm.
populations. And what we know is that aspirin is useful in a small group of patients for primary prevention. Remember, aspirin should be used by all patients who had any form of cardiovascular event or who have atherosclerotic vascular disease, uh, right? So if you have had a heart attack, you had a stroke, you had peripheral arterial disease, all these patients need to be on aspirin. So this is not for that. We're not talking about that group of patients.
We're
We're talking
talking about
about
a
people who
normal,
do not
regular
have
person. Yes.
this thing. So basically, we can use aspirin, low dose aspirin in patients who we think are going to be at very high risk for cardiovascular events in the next 10 years or so. So you should talk to your doctor, find out. They will they will look at certain scores based on certain numbers you have and decide what your risk for cardiovascular events are in the future. And based on that number, we can decide, especially in the 50 to 59-year-old age group, there is a benefit. Remember, but aspirin also has certain benefit in a couple of other things. It does
Mm-hmm.
decrease certain cancers, so that's another additional benefit, especially with colon cancer. And secondly, it we know that aspirin has helped with patients with elevated LP little a. Actually,
Yeah.
there's some data which has come out, which certain sub studies which have looked at aspirin. Patients with elevated LP little a had fewer cardiovascular events when they were on aspirin. So that's something for us to look at too.
I think the bottom line, I think the bottom line is it is very important for every person to know their individual risk factor or risk profile. And based on that, they can make decisions. But when you don't know your individual risk profile, you don't know your family history, you don't know what your blood pressure is, you don't know anything about, you don't know what your hemoglobin A1C is, it's going to be very difficult to pick and choose from what is out there as what is needed. And I think that's what happens. People don't want to go to a doctor, don't want to get blood tests, but just get, random information from different sources and then get confused. And I think the most important thing I would recommend, and you tell me if you agree as well, is to figure out where you stand in the risk factor profile and then decide what you need to take.
I agree. I think, we've moved away from, we've kind of moved towards what we call individualized medicine, right? So you have the patient in front of you, and I need to assess that patient's risk. And it may not be similar to the patient I saw before or the patient I'm going to see in the future. And that person's individual risk will depend on multiple factors, and we need to put all that together. And I think what's exciting is that probably AI will help us even better in the
Yes,
future to
hopefully,
individualize
yes.
this risks in these patients, because you can put in multiple parameters and understand the risk so that we can offer the best therapies available.
And I think we would be at fault if we don't discuss statin. I mean, right now, statin is the biggest cholesterol medication, most popular cholesterol medication. But do you think we will use less of statins and more of PCSK9 inhibitors or bempedoic acid and things like that? Or do you think statin is still going to rule the market?
I think statins have since the late 1980s we've had statins, and it's clearly shown benefit both in primary and secondary prevention, and it's probably the bedrock in
Hmm.
lowering LDL cholesterol. So these other medications we have do the job well, like PCSK9 inhibitors exactly decrease LDL cholesterol by more than 50%. But again, the data is only the last 10 years. So I wouldn't throw the baby out of the cradle yet, right? So statins clearly is it's generic. We have such low cost option to lower your LDL without significant side effect profile. Yes, some patients do not tolerate statins truly because of the myalgia side effect, which is the
The
most
muscle cramps and things like that,
consequences.
yeah.
So if you have that, now the good news is we have a lot of other options, but still statins are probably the cornerstone. Remember, lowering LDL still is our goal. I know there
Yes.
are other things we need to look at. That is after you lower LDL. You lower LDL and then you look at the other parameters we need to address.
Well, Raj, thank you so much. I know we are right now sitting on a Saturday early morning, and before he goes to rounds and doing this. So I truly appreciate you taking time. So let's close out with, what are the 1 to 2 things you wish every listener knew about their lipid profile before they panic and come and see a cardiologist?
Okay, so few things I would say. Don't get hung up on numbers. Look at when you look at your lipid profile, look at it in a slightly more educated fashion. Just because your lipid profile is all in the black, not in the red, doesn't mean things are okay. So you need to look at each number with a certain lens. I would say LDL cholesterol, definitely that number for a general population. I'm not talking about specific population, but general population needs to be less than 100. In terms of triglycerides, if your numbers should be less than 150. If it's above 150, especially at a fasting level, this is not this is alarm bells not just for cholesterol, but it's really alarm bells for other things going on in your body, right? You may be diabetic or you're prone to developing impaired glucose levels. And then, really, the lipid panel is one part of your cardiovascular health. It is not
Yes.
all of your cardiovascular health. So just because you
Yes.
have normal lipid profile doesn't mean you're not at a risk for heart attacks or strokes. We know, as you as an interventionalist should know even better, that half the
Yes.
patients you see in the lab with myocardial infarctions have normal lipid profiles.
And that's literally the most repeated question on the table after their heart attacks. But my cholesterol levels are okay. Why am I, on the table? I'm like, yes, that's not. It's just one side of the story, and it's not the entire picture. And I think That's the most important message we would like to get out there today. So, Raj, thank you for this incredibly insightful conversation. We really deep dove into all the little teeny tiny aspects, all the way to the mRNA level. So, I appreciate your time and all the information you've given. Thank you so much.
My pleasure, Arasi.
Thank you. Thank you so much for listening. If you found us valuable, you can subscribe to the show on Apple Podcasts, Spotify, or any of your favorite podcast app. And also, please consider leaving us a rating or a review, as that helps others find the podcast too. I hope you have a great week ahead.